name is Michael Oyer, and my co-host, co-moderator today is Albert Muraya. Albert, karibu.
Thank you, Michael. Thank you, everybody. We welcome you to this webinar. We pray that you'll find it engaging. We have a wonderful panel before us, and we would like to introduce them before we begin. The webinar will be opened by Professor Jogona, Deputy VC of USIU-Africa, alongside Dr. Pamela Kaithuro of ISSUP Kenya. Professor Jogona, are you here? Perhaps you'll be joining us later. And then after that, we will introduce our moderators. So as we wait for Professor Jogona, Dr. Pamela, perhaps you could come in and just welcome us and introduce ISSUP Kenya.
Good afternoon, all of us. It's a good thing that we are here this afternoon. This webinar comes in at a very important date, the 10th of October, when the world is celebrating the Mental Health Day. The statistics really are worrying for us. And the thing being that mental health is a universal human right is very notable also, because as it is, everyone has a right for quality mental health service, accessible services, quality services, and ease of access as well. There are international frameworks that speak to mental health being a universal, of universal importance, that we should be able to bring everybody on board, very inclusive. Everyone needs to be able to get services. And that becomes very, very important that we professionalize the space of substance use prevention. And ISSUP comes in handy as one of the organizations that is very critical in mental health issues. So I introduce who ISSUP is briefly so that we can be able to relate with ISSUP Kenya. So ISSUP is a global non-profit, non-governmental organization and works within national chapters so that the national chapters become the focal points for the various nations to ensure that the mandate of ISSUP is being implemented with consideration of the relevant cultures, the environment within the counties. ISSUP works very closely with the key institutions like UNODC, the World Health Organizations, and also African Union. ISSUP Kenya is legally registered in Kenya according to the laws, and is administered by the executive committee that is voted in during an AGM, and the implementation of the various objectives are achieved through various committees. And we have liaison offices across the country where we have our ISSUP members. Our vision as ISSUP is basically to make sure that this science of addiction is understood and it is done professionally at prevention, treatments, as well as recovery. We connect, train, and enhance knowledge of the substance use professionals at all levels by undertaking quality, evidence-based, and ethical practice across the country as a ISSUP chapter. Where do we get our membership from? Who is able to qualify to be a member of ISSUP? Really, when you look at this network, it virtually covers everyone. And that's why we have 4 categories. We can, one can join as a student, as long as you are going on in training, and then you can upgrade to whichever of the other 3 levels. We have regular membership that takes non-professionals, because we know the space of substance use has many players. So we have people who even do voluntary work family members, community organizers, and non-accredited members who can be able to join as regular members so that this message is able to reach everyone. We have also professional members that draws from other professionals that maybe have not basic training in substance use prevention. And then, of course, the highest level is in drug demand reduction, which is the persons who have a bit of qualifications in substance use prevention. So ISSUP exists to share knowledge, to create awareness, as well as to promote research in the substance use area, to be able to create a network where the professionals can be able to interact and collaborate in this field. As you are aware, substance use disorders coexist with other mental health conditions as well as with physical illnesses. So the more of the critical mass that we have that can do interventions at the community level, the better for us. So our trainings are globally accredited. So anyone who trains at whatever level, they are able to do a certification that gives them a credential at their level and grow within the profession. Besides trainings, we also organize opportunities like this one of today to be able to share knowledge as well as best practices for the people who are implementing. What are some of the training curriculums that we offer, or what we would call our products? Our products have been developed scientifically through research. They are evidence-based and high quality. We have 3 levels of training: the universal prevention curriculum, the universal treatment curriculum, as well as the universal recovery curriculum. These curriculums are available online, and they can be instructor-led or self-led to make it easy for whoever is interested to really partake of this. And there are various modules depending on the progress that you want to make. But the most important thing is basic knowledge is built so that our people are responding professionally. Because as it is, substance use disorders are mental disorders that are very complex. And if they are not well understood, then we have a lot of people getting a wrong deal, and therefore we will not be helping our people. So that's why ISSUP exists, to be able to professionalize the mental health space. And we can be contacted through the addresses here. So I wish to welcome all of us and say, I hope we can be able to share widely our experiences, our knowledge, and this should not be the last presentation we make. We'll have more opportunities because this information is needed for our country, requires a lot of support. Welcome and enjoy yourself. Thank you.
Thank you very much, Dr. Pamela Kaiduru, for letting us know more about ISSUP, and also for the interest and the push that you're engaged in us taking care and making sure that substance use is prevented, and for bringing in the people who are critical in helping. I'd like to now take this opportunity to welcome the DVC at USIU-Africa, Professor Amos Njuguna. Karibu sana for your welcome remarks. We'd given Dr. Kaiduru 10 minutes. She took the 10 minutes. We offer you the same 10 minutes. Karibu.
Thank you. Thank you very much for the kind remarks, Michael. And thank you. We've got to a very good introduction of what the International Society of Substance Use Prevention and Treatment Professionals do. And we've really appreciated the good work. I just want to, I'm not an expert like my colleagues Stella and Joseph, as well as Dr. Pamela Kaithuru. But I will give you just a quick dimension of what we as a university are up to with regard to what we do and the topic of the day. In the last 2 years, we have adopted a strategy that's talking about moving from knowledge to problem solving, which simply means that we have all these students, faculty and staff, and colleagues, and for many years, we've been doing knowledge-based training, which is good because everyone gets the knowledge. But then the next question is, how is this knowledge useful? Can we now move another step and get into problem solving, where our students, faculty, and staff are then able to use the knowledge that we give them to go out there to the community and really solve the problems. Now, in this context, we have defined these problems as the complex challenges that we are facing globally in the context of sustainable development goals. The topic of the day is very important because if we do not take care of the mental wellness, then there is nowhere we are going as an institution, as families, as individuals, as a region, or as a globe, as we inch towards the year 2030, when the Sustainable Development Goals are supposed to be achieved. And looking at that framework, the target 3.4 is much more about the mental wellness, and it's talking about reducing instances by up to a level of 33% or 1/3. If we could be able to reduce that, because if we are not doing that as a university, even if we continue providing education, and we are talking about quality education, there is no way we provide it if our young people, our faculty, our staff, and the communities where all of us come from are not achieving the mental well-being. We cannot start talking about good health. We can't start talking about agriculture, food security. All these things that we are referring to cannot be achieved. Most importantly, we are training young people to go to the job market and saying, hey, we want you to go out there, have decent jobs, be fruitful and productive individuals. If we cannot keep their mental well-being in place, then we will have problems. And the problems will be that we are wasting the resources, human resources, physical resources, and even financial resources, putting everything together and then losing through the drain. We end up losing that. Forgive my economic background, because I look at it and say, what are the tangible economic benefits we get out of this? As a university, therefore, we are taking this matter very, very seriously. Because, and most importantly, training and ensuring that we are contributing, and even the methods, the approaches we use, the systems, the processes, and the people we put in place really understand and have a leader mindset that says, we truly understand that the mental well-being of individuals is important, and we are going to support it on that. I know my colleagues will be talking about the community activities that we are doing, so let me not plug in there, but plug into the fact that we are committed to pursue this endeavor and support activities like are happening in this webinar, to be sure that we are making the change and the difference that we so much desire to make. So with that, let me pause there so that the experts can really come in and help us refine this topic. And anyone listening to us today, feel free to interact with United States International University in Africa, because this is a matter that we pay a lot of attention to. We have exciting programs that run, and we also welcome everyone within the ecosystem to support us in this endeavor. As we also support you, colleagues, anywhere we can come in, let us know, and we will be the first ones to knock your doors. Thank you, and over to you, Michael. And good to see you again. We were together on Friday.
Thank you, Professor. And thank you, Dr. Kaiduru. This webinar is sponsored and brought to you by ISSUP Kenya and USIU-Africa. And we're looking at substance use prevention, a responsive strategy to enhance mental health in Kenya. May I encourage you to let us know where you fall in the family of concern with regard to substance use, so that we know, am I a person who's affected or affected only? Am I a professional involved? Do I have whatever the information you'd want to share with us in the chat as we proceed? But right now, I'll hand it over to Albert for some introductions and the beginning of our keynote presentations. Karibu, Albert.
Thank you, Michael. Thank you, Professor Jogona, and welcome once again to everyone who's here on this webinar. As Michael has said, we encourage you to write in your questions. We are trying to collate them, and we'll present them to the panelists as we proceed. So at this juncture, I'd like to introduce all our panelists. I see that they're all here now. And I'll start with Honorable Anthony Kibagendi, MP, who is a chairman of the Parliamentary Caucus Against Drug and Substance Abuse. Karibu sana Mheshimiwa. Thank you for gracing us with your. We will come back to you shortly. I also want to introduce Dr. Susan Getao. She's a founder and director of Elewa Ulevi. This is a outpatient consultancy for drug and substance use disorder. Karibu, Dr. Getao. Dr. Getao will be our keynote presenter, and we'll come back to her. And then I also want to introduce the rest of the panel. You've already met Dr. Pamela Kaithuru. She's the president of ISSUP Kenya. She's also a counseling psychologist and a climate advocate. And then there's Dr. Joseph Njoroge, who is a faculty member of USIU-Africa. Karibu sana, Dr. Njoroge. And then finally, we'll have also, last but not least, Boniface Durango, who is the chairman of APRAC Kenya. APRAC is the Association of Prevention Rehabilitation Association of Kenya. It is the umbrella body that groups all the rehabs, the rehab owners and directors in Kenya. So Boniface Durango is a significant advocate for drug demand reduction here in Kenya. Karibu sana, Bwana Durango.
Albert, don't forget, there's one more lady.
Oh, yes, and then, yes. Thank you, Michael. And then there's Dr. Stella Nyagwecha, who is a faculty member of USIU-Africa, and our co-host, in fact. She was a primary in putting this webinar together, and we'll hear more from her later. So karibu sana, Dr. Stella, as well. So with that, I'll go to Dr. Susan Getao and ask you to proceed with your presentation. And then Honorable Kibagendi will come to you after that for your remarks. Thank you.
Good afternoon, everyone. I'm glad to be here. The theme for this day, October 10th, is mental health as a universal human right. So today I want to look at this in a more deep way. I'm looking at the correlation between drug abuse and mental health. Allow me to go off camera for now And I hope everybody can hear me. So on this day, I want to do the introduction of what mental health is. And we are saying it is a state of mental well-being that enables people to cope with stresses of life, realize their abilities, learn well, work well, and contribute to their community. So as we go on, we are going to look at the mental disorder. How is it characterized? And we are looking at an individual's cognition, emotional regulation, or behavior. It is usually associated with distress and impairment in important areas of functioning. We know that there are very many different types of mental disorders. So I need to talk about substance abuse. And substance abuse refers to the excessive use of a drug in a way that is detrimental to self, society, or both. And in my definition, it includes both physical dependence and psychological dependence. So substance abuse refers to excessive use of a drug in a way that is detrimental to self, society, or both. And addiction is a brain disorder involving compulsive substance use despite negative outcomes. This is a very complex condition with both psychological and physical elements that are hard, if not impossible, to separate. Substance use disorders happens when the substance that one is using causes clinically and functionally significant impairment to the individual that is using the substances. What are we looking at with SUDs? We are looking at health problems, impaired control, risky use of substances, social impairment, and failure to meet major responsibilities. Currently in our country, we are noticing a lot of risky use where people are combining multiple drugs of substances. For example, before we have always looked at 3 or 4 main drugs, that is alcohol, tobacco, marijuana, and what we call hard drugs. But of late, we are realizing that the younger generation are mixing these things up. So you find somebody using cocaine and heroin, and they call that a speedball. Others are mixing marijuana and tobacco, or mixing marijuana and cocaine, or mixing marijuana and heroin, which they call a cocktail. So the more people use many drugs, polydrug using, the worse the risk, the worse you hear of overdoses, you hear of people developing serious mental health disorders. So the link between mental health and substance use is people are using substances because of the impact they have on the way they feel or think. Now, the substances will depend on the individual's mental and physical state, as well as the nature and the intensity of any mental distress that they could be having. So it also depends on the factors. What are you using? The quality of the drug that you're using. How are you mixing them? Are you including prescribed medication? It could be for your mental health, or it could be you're buying it on the street. This is what we call tap-taps, Legos, Bugizi. You just find them on the street and people are using them to get high. It's quite saddening that even now as I sit here, people are mixing marijuana with antidepressants. And when you talk to the peddler, they think they know so well. So they tell you why we mix antidepressants with marijuana so that our clients do not lose their mind. So when you do testing, that's when you find somebody's testing for TCA and you're wondering, are you using this? They tell you, no, I just use marijuana. They're even combining methadone with marijuana. They're also combining petrol with marijuana. So when you're taking this, you don't know what you're taking. So what route are you using? Are you smoking it? Are you sniffing it? Is it under the tongue? Is it IV? Is it rectum? Is it vagina? We have very many routes of administration, unlike before how things were. So this link between mental health and substance use, I want to look at it this way. Mental distress may lead to substance use as a way of coping with other problems that this individual may have. Substance use in itself may trigger or increase mental distresses. And also substance use can make a pre-existing mental distress worse than the way it is supposed to be. So substance use result in symptoms that resemble those associated with psychiatric diagnosis. Somebody starts hallucinating, paranoia, anxiety, depression, but this is just coming from substance use. Also, substance use, people who have effects of their psychiatric medication, sometimes they self-medicate so that they feel better. The common one that I hear as a clinician is where somebody is on antipsychotics, they feel slowed down. So they prefer using cat to feel a high in a kind of energy. Others, they use substance as a form of self-harm. This is what we are calling a way of coping. So some people are harming themselves by using substances. Now, how would you recognize someone who has dual diagnosis? Dual diagnosis, meaning you're having more than one, either substance use or a mental health use or even another condition. So these are some of the questions we ask at our center when we are dealing with our clients, so that we can know, do they really only have a mental health issue or do they only have a substance use? So these are some of the questions. Have you noticed a relationship between your substance use and mental health? For example, do you get depressed when you drink? Or do you drink when you feel anxious? Another thing you can ask the client, has someone in your family grappled with either a mental health disorder or an alcohol or substance use disorder? Do you feel depressed, anxious, or otherwise out of balance even when you're sober? Have you previously been treated for either your addiction or your mental health problem? Did the substance abuse treatment fail because of complications of your mental health illnesses? So when you're able to do this as a clinician, you will be able to know whether this person has dual diagnosis or they have one diagnosis. I want to go back to where we have come from. I started working in Mathare Hospital in 1997. By then, there was no rehab. There were still drugs were still there. So in the 1970s, that's when heroin came in. The alcohol, the tobacco was still there, but heroin came in. Around 1980s and 1990s, cocaine came in. Initially, it looked like a drug for the hippies, the people who didn't want to feed, they wanted to keep traveling from one state to another. Then come the 2000s, we got crack cocaine. We started having the benzodiazepines were being abused a lot, the opioids, painkillers. In 2010s, the pain medication started being abused. There was a rumor that if you were prescribed for the pain medication, which is opioid, you could not get addicted. So in some country, mostly in the US, the salesmen really convinced doctors to prescribe for people painkillers. And from then, things have gone from bad to worse. In the 2020s, where we are now, we are talking of fentanyl. One of the worst drugs, 50 to 100 times more stronger than morphine, available. We're also talking of a newer drug, xylazine, which has come up where people are becoming zombies and death because of overdoses are just out of this world. So as a country, we are moving from where we were to where we are going. The drugs that were there in 20 years ago and the ones that we have now in my country, they are changing. Before we talked of just the main ones, the alcohol, the tobacco, the cigarettes then, bangi, marijuana, and then we talked of cat. Cat was not really within Kenya. It was specific for a certain place, so it had not really come. Now, as we are dealing with people with addictions, we are talking of alcohol is there, but we don't know what we are drinking. There's methanol, the Macalis that have come in. You don't know what is inside those Macalis. That's why people are losing sight. People are dying with liver cirrhosis faster than any other time before. We are talking of tobacco, we talk of now vapes. As I sit here, the vape is the hottest thing for teens right now. And they don't know what is inside the vape. We're having things we are calling bath salts. That is synthetic cathinol. We're having CBD. We're having THC. We're having flakka. These are things that are in the vape and very addictive for that matter. We are talking of smokeless tobacco, Kuber, Chavis, we can talk of Lyft, we can talk of Vero. I don't know whether I'm supposed to be mentioning those at this point, but they are just seriously addictive, and young people have been convinced that there are no effects for these substances. So we are noticing drugs changing. Heroin now, it's coming in many forms. Before we had brown, now we have white. We have ecstasy, it's here. Methamphetamine is here with us. Crystal meth is here. So these drugs are here, and they are going to interfere with our young generation because of their curiosity, and also where people are telling them that these drugs are safe. So when we look at substances like alcohol, cannabis, stimulants, and opioids, all these are psychoactive substances, and they may change the individual's brain function and structure after chronic use. This can result in cognitive and behavioral changes, and some of these defects may remain even after someone stops using these substances. So the exact mental or cognitive effects of substance use may vary depending on the type of drug and the duration this person has used. Then substance use disorder may also exacerbate symptoms of other mental disorders. And mental and early drug use is a very strong risk factor for later development of substance use disorders. It may also be a risk factor for developing other mental illnesses. For example, frequent cannabis use in adolescents can increase the risk of psychosis in adulthood in individuals who carry a particular gene variant. So let us look at short-term effects of these drugs and how we connect that with mental health effects. So we know alcohol, the feelings of euphoria, reduced anxiety, finding that you're easing in social interactions, and immediately it's withdrawn from you, the irritability and anxiety will start coming on you. We can look at cannabis. Cannabis actually enhances sensory perceptions. It gives a feeling of euphoria and relaxation. This is what I hear from the clients I talk with, that if they take marijuana, in our tuliza too, you chill, una chill too. Everything is beautiful, you love everybody. As you continue using, anxiety kicks in, and immediately it's withdrawn from you, the issues of irritability, anger, confusions can come in. These are just short-term effects. Now, as I take a cup of tea, some water here, I'm looking at a lady here who is carrying marijuana. But when you're looking at it, you will notice it's like she's carrying a baby. But in reality, she's carrying marijuana. And we can look at, that is a picture there, sorry, it was not coming on. So she was caught somewhere, and for sure nobody would have suspected her. So in Kenya right now, marijuana use is on the high. The young people have been convinced that marijuana has no side effects. It grows, it can be used for enhancement for sports, for understanding more in class. There's a lot of rumors going around. And because other states have legalized medical marijuana, our young people are saying they also want to be using marijuana. I don't know where they are sick, but they are insisting that the use of marijuana is normal and allowed and it should be legalized. So as we continue, we talk of benzodiazepines. In the street, the word you hear is tap tap, Legos. Sometimes Rohypnol is used a lot, is a benzodiazepine, D5, Cs, those are the words you hear. So what it does, it brings drowsiness, concentration issues, dizziness, reduced anxiety, and serious problems with your memory. Heroin. In the year 2000, heroin was only brown. It was known as brown sugar. It has also changed. So what it does, the brown sugar, known as kete on the street, it has very many names, monkey on your back. It has many names, Bibi Mwarabu, because apparently it's expensive. It brings feeling of euphoria, what in the street they call kuyoyoma. So upon withdrawal, restlessness at a different level. When we're looking at withdrawal symptoms of heroin, sometimes they are just the worst withdrawals I've ever experienced are for heroin because of the pain, abdominal pain, the diarrhea, the confusion, the feeling cold and hot. So heroin is still here with us. Then we can look at the prescription drugs, which are being prescribed for pain relief. They bring drowsiness and the feeling of euphoria. So when we talk of prescription opioids, they are supposed to be prescribed by a doctor, either a psychiatrist or a physician, and normally they know how to do it. So you cannot be prescribed for many days because they have potential for abuse. Yet people go over the counter. You're not supposed to get this over the counter, but we know you can get this very easily around here. So we can talk of methamphetamine. This is one drug, mostly from the people I'm interacting with, is coming from South Africa. And it comes in and looks like glass fragments. You can use it through smoking, swallowing as a pill, others snorting, injecting that powder. I've seen people dissolving it in water or alcohol. So when people take this drug, the problem is the high does not stay for long. It fades away quickly. So after 20 minutes or so, you will find that they will want to have another kick. So it increases the need of doing it again and again and again and again. Then we can look at common drugs that are associated with long-term SUD use. So long-term with alcohol, depression comes in, anxiety. A lot of people who have alcohol use disorders, we need to always check out whether they are suffering from depression or anxiety. Learning and memory problems are very common with people who are using substances. And of course, social problems. Everybody else knows you have a problem apart from yourself. The prescription opioids, there's a very high risk of overdose. With the methamphetamine, we're having people going into anxiety, confusion, lack of sleep, mood problems, violent behavior, paranoia, hallucinations, delusions. So how would the psychiatrist or the addiction professional know? Is this person becoming psychotic, or is it that the drugs are presenting this? That's why we were talking about the dual diagnosis. Heroin, risk overdose. It's unfortunate I've lost some of my clients through overdose. And when we talk of tobacco and nicotine, the teens right now, well, they are really into nicotine, whether it's the smokeless one or the vapes are the hottest thing right now. So they affect the development of the brain circuits that control attention and learning, irritability, attention defects, sleep problems, and immediately we withdraw, they're going to start having depression. Cannabis brings a lot of mental health problems. Research is still going on about this. And once it's withdrawn, there's a lot of irritability, unable to sleep, and anxiety. So During this very hot stage of adolescence, changes in the brain can occur. So we are noticing that if adolescents are introduced to substances, they are very vulnerable to mental health disorders. And when you're still young and you're using, they can hinder development of the brain. It can affect how the brain functions, the learning, memory, behavior and control, the reward center, emotional development, and decision making. That is why it's very hard for a teenager who is using substances to be in a learning institution. So early substance use is a very high risk factor for later substance problem. And it's also a very high risk factor for mental disorders. So addiction disorders are complex illnesses that are strongly influenced by individual genetics and environmental factors. Some of the areas of the brain that are affected by substance use, we know that the circuits that use dopamine are typically affected by addictive substances. How does this happen? Dopamine pathways have also been implicated in ways stress can increase vulnerability to substance use disorder. So dopamine is a neurotransmitter, and it's normally released during any pleasurable experience, whether it's eating, having sex, exercising, enjoying music, and all that. So when you're using substances, once it connects with the reward circuit, it reinforces that behavior because you keep looking for that pleasure. So every time you use a substance and you get that pleasure, your brain will be trained to keep repeating the use of drug so that they can have that experience of pleasure. Stress is an environmental risk factor for a range of disorders. It is one like the one that is most likely you link between substance use and mental disorders. For substance use, it can make changes in the brain structure and function, which will then trigger underlying or predisposition of developing a mental health disorder. These are the risk factors. Peer influence. A lot of people are talking, I was introduced by my peers. This is what is going on. Family environment. If you're growing up in a family where you find that there was alcohol or drug use has been normalized and it's not a big deal, what is our culture doing? What is the social norms? In our culture, if a man is drinking or using substances, we have a way of justifying it. If it's a woman, that's a story for another day. Social norms, socioeconomic factors affect this a lot. Where are you coming from? Whether you're doing well or you're down there, there's a connection between socio-economic factors and substance use. And of course, something we are talking about now, we've realized that trauma is contributing so much to substance use, adverse childhood experiences that were never dealt with. So when we're looking at somebody using substances, we should always go, what is underlying the substance use? So co-occurring disorders refers to the condition of having at least one mental or medical disorder and at least one substance use disorder. Now, the prevalence is that 45% of people experiencing a substance use disorder have at least one mental disorder. I want to repeat that again. The prevalence of people experience a substance use disorder have at least one mental disorder. So according to a research done in 2019, 28.8 million adults had either a serious mental illness or a substance use disorder. So those are our resources there. And as I come to the end of this, no child hopes to be an addict when they grow up. No parent hopes to raise one. No human is immune to addiction. These are our interventions. We talk of psychotherapy, Most of the people who are psychologists, psychiatrists here know about CBT, DBT, family therapy. They normally address issues, develop coping skills, and promote what we call behavior change. We have MAT, medication-assisted treatment. We talk of methadone, we talk of buprenorphine, naltrexone. They are able to help manage withdrawal syndromes, reduce craving, and support recovery. We also use antipsychotics for those with mental health disorders, antidepressants, or mood stabilizers, just to help this person who has dual diagnosis. Other intervention is about AA, support groups. They provide valuable peer support and a sense of community for individuals in recovery from substance use disorders. So these programs will help the individual, especially those who have lived the experience, to provide understanding guidance to the others who are experiencing addiction or alcoholism. The best treatment is the integrated treatment, where we address both the substance use and the mental health condition spontaneously. So integrated treatment is a comprehensive care, and it is very good because it increases the chances of successful recovery. Other intervention is self-help and lifestyle changes, where those suffering from SUD and mental health conditions can engage in regular exercises, practicing management techniques, mindfulness and meditation, improving sleep hygiene, fostering a supportive and healthy social network. Case management and supportive services, they help the individuals access the necessary resources and support. In Kenya, we are not yet there where other countries are able to look for housing, employment. At least we can look for healthcare and ongoing continuum of care once they leave the rehab. And also we can help them with maintaining a good health, whether it's physical or mental health, so that they can maintain recovery. Prevention, this is one very strong point for ISSUP. We do a lot of education and awareness, but we are doing this with accurate evidence-based information about the risk and consequences of substance use. So these programs can be in schools, communities, and other settings like the churches, the mosque. And what you bring out here is the harmful effects of substance use. You need to educate individuals about the impact on physical, mental, and even relationships, because the overall well-being is affected by substance use. Life skills or resilience training is very essential because it can enhance people's ability to make good, healthy decisions, manage stress effectively. Life skills programs, they will teach you how to solve your problem, decision-making, how to communicate, how to be assertive, and your emotional regulation. So these skills can build resilience and provide individuals with alternative ways to cope with challenges without resorting to substance use. So we need to strengthen the protective factors. We need to identify them first, and then bring in the positive relationships, strong social and support networks, involvement of extracurricular activities, access to education, opportunities, a sense of belonging. This effort should be made to create environments that actually promote protective factors, especially for our vulnerable populations, the young people, children, adolescents, people who have lost their loved ones, etc., etc. Then we need to address the risk factors. We have to recognize the risk factors that are associated with substance use disorders. So the risk factors may include what we talked about: peer pressure, the family history of substance use, exposure to drugs or alcohol, mental health problems, socio-economic disadvantages. So prevention programs should aim to reduce the influence of risk factors and provide support and resources to these specific individuals who have a higher risk of substance use. the issues of policies and environmental strategies. So implementing these policies that we have, and we have very good policies in Kenya. These policies can discourage substance use, can also regulate issues of advertising and marketing of substances, restriction, who can access some places, how available are these substances, what is the legal drinking ages, these promoting smoke-free environments. These are things that can really help us as a country, where we are promoting positive, healthy alternatives. We have recreation activities, better than running to that Friday, running somewhere to go drink or have fun, as we put it. So we need to have those positive outlets so that we can reduce the appeal of substance use. Parents, the family involvement. As a parent, you play a very significant role in prevention of substance use among children and adolescents. How is that? Open communication, setting clear expectations and boundaries, providing parental support and monitoring can help reduce the likelihood of substance use initiation. So parents should focus more on prevention programs. They can offer guidance and effective parenting strategies, and especially for teenagers, communication skills, so that they're able to become assertive. So in my conclusion, it is crucial to recognize that substance abuse can be both a cause and a consequence of mental health disorders. Individuals struggling with mental health challenge may turn to substance as a way to self-medicate and alleviate their symptoms temporarily. However, substance abuse often leads to worsening mental health symptoms and can create a vicious cycle of dependency and psychological distress. Thank you.
Thank you very much, Dr. Susan Gitau, for that most comprehensive presentation. You covered quite a lot of ground there, and you really were truly our keynote speaker. And so as we move along, I'd like now to invite Honorable Anthony Kibagendi, who is a chair of the Parliamentary Caucus on Drug and Substance Use Disorder, to give us his remarks. So, Honorable Kibagendi, the floor is yours.
Thank you for this invite, and a big thank you for the organizers of this particular webinar. I would like to appreciate Dr. Susan Gitau for that comprehensive and excellent presentation. Webinars such as this are instrumental in creating awareness. Mental health education is something that is critical in our community, and it needs to start all the way from our schools, our churches, community barazas, and it's vital to educate masses on mental health, to dissociate them from the misplaced notion that it is a self-inflicted issue, but an illness, and also to deal with the stigma that comes with matters to do with mental health. Allow me to take off the video. Now, on the topic of today, a responsive strategy to enhance mental health in Kenya, we, as a parliamentary caucus, probably I introduced the parliamentary caucus. The caucus is not a committee of parliament. The caucus is an association of members of parliament who have come together to try and create awareness around matters to do with the effects of drug and substance abuse, as well as matters to do with mental health. And it was founded sometime in October last year, and we've held a number of forums. We've been involved in a number of forums with NACADA and the Ministry of Health, the department that deals with HIV and AIDS awareness and treatment, that is the National Syndemic. We have also had a number of meetings with organizations that are in this space on matters to do with drug and substance abuse, and even mental health wellness. Some of the areas we are looking at is issues to do with compassion, and we as an parliamentary caucus, we don't necessarily we are not in competition with any organization. We are not in competition with NACADA or the CBOs or even ISSUP. Our part is to complement the efforts of all these organizations and government agencies that are trying to ensure that we rid this country of the menace on drugs and substance abuse. On matters compassion, we are looking at an amendment of relevant laws for use of kind words, such as people living with mental illness, instead of terms as people that are insane or people suffering from mental disorder, in line with the Mental Health Act as amended in the year 2022. We are looking at proper implementation of the Mental Health Act while in place, and it provides for the care, the treatment, rehabilitation of people with mental illness, the procedures for admission, treatment, and general management of these persons with mental illness in line with the provision of the Act are yet to be fully implemented. Ways in which implementation can be effected include building capacity for healthcare professionals in public hospitals on mental health issues. We are also looking at financial empowerment of the Ministry of Health to enable it to realize its obligation. You realize there was a board that was put together, but they do not even have an office. They do not even have a physical location. They don't have a CEO or even personnel to ensure its operationalization. We are also looking at pushing for increased access to counseling services that can be supported through NHIF. There are some restrictions around how far NHIF or the health insurance fund can go, and these are some of the areas we are working on, amending some of the provisions and pushing it to take care of it, the medical care in its entirety. We are also looking at prioritizing public art and heritage conservation efforts that contributes to community connectivity, identity, which encourages interaction and places attachment on this, some of these things. A sense of belonging in community promotes connectedness and positive mental health. So as a caucus in Parliament, we are looking at engaging with some of these organizations, whereby we get to even do capacity building forums for the members, and as well as members of the community that are willing to go out there and create awareness. The caucus is also looking at partnering with the United Nations Office for Drug and Crime, whereby we seek support of every kind so that it can go into CBOs, the community-based organizations, and all other relevant organizations that are in this space. We are looking at having an engagement with ISSUP sometime later this week in Parliament with the caucus. And I appreciate, again, the organizers of this particular forum and look forward to further engagements. Thank you.
Thank you very much, Honorable Kipagendi. And we're looking forward to having you continue with us as we now look to open up the discussion to the panel. Again, a reminder of the panelists, Albert, as we get into the discussion.
Thank you, Michael, and thank you, Mheshimiwa. We do look forward to continuing engagement with you. We thank you for honoring us with your presence today. So I just want to quickly reintroduce the panelists. You just heard from Honorable Kibagendi, who's one of the panelists. Dr. Susan Gitau, you just heard from her. She is a director at Elewa Ulevi and a former vice president of ISSUP Kenya. And then we have alongside her the current president of ISSUP Kenya, Dr. Pamela Kaithuru. You've seen her already. And on screen we have Mr. Boniface Dirango, who is the chairman of APRAC Kenya, the association that groups all the rehab owners and directors. And then we have Mr. Joseph Njoroge, who is a faculty member of USIU and a long-time supporter of people in recovery. So I welcome you all. I ask you all to put on your cameras and your microphones, please, as we proceed with this part of the conversation. And Michael, I'll ask you to set us off.
Great, thank you so much. I feel that it's imperative to just continue with a question that has been asked, Honorable Kibagendi, with regard to public managed rehab centers. Is that something that will be coming along soon or increasing as part of your policy influences? All right, as we wait for Honorable Kibagendi to join us again and put on his camera, let me give each of our panelists 2 minutes to respond to both what Dr. Gitau has presented and what Honorable Kibagendi has presented, and just chime in with your specific angle to what we're discussing today, and that is prevention, and specifically a responsive strategy that can enhance mental health. So ladies first. No, we won't go ladies first, unless Dr. Nyagwencha, you're going to contribute, because we've heard the other ladies speak. So I'm going to be biased at the risk of, yes, go ahead, Dr. Nyagwencha. 2 minutes, please.
Okay, thank you very much. I just wanted to probably bring up what USIU is doing, because I believe that all of us should be doing something where we are. At USIU, we have come up with policies which have been stipulated in the student's handbook on alcohol and substance use. We have awareness campaigns, which basically we call them Drug Awareness Week, where we hope to prevent substance use. And therefore, a whole week is dedicated to that. We have, during orientation, we talk to new students, and we have classes where basically we teach or educate the students on the risks and what constitutes a drink, and reinforce rules and regulations. We send out educational materials to students on email and on notice boards. We have a special group of students whom we call peer educators and counselors, who are trained to act as bystanders, and they support other students basically struggling with substance use. We collaborate and partner with different stakeholders, just as we have collaborated today with ISSUP, and we look forward to more collaborations. And we carry out surveys among students, staff, and faculty to be able to just understand the challenges they are facing and be able to come up with programs to help them deal with the challenges that they are facing. So basically, we support struggling students through counseling, referral by faculty when they notice a student is struggling, and we also offer aftercare to those who have gone through rehabilitation. And so as USIU-Africa, we are committed to supporting the students to deal with the issues that they're struggling with, to prevent it resulting into substance use disorder.
Thank you very much, Joseph Njoroge. You're also at USIU. Are you going to say the same thing or add?
Well, see, thank you, Michael. Yes, there's quite a bit. But first of all, I'll say thank you very much for having me. It's very nice to be here in this caucus to talk about, this not the caucus, see the MP has influenced me in this place to be able talking about this webinar, talking about these things. So looking at what Dr. Gitau talked about, I think she touched a number of things and quite pertinent, I believe. But I'm more excited even to see lawmakers this caucus is formed. It's very, very important, because just the other day I was seeing a client and insurance was paying. So when I was filling the form, I asked them, are you sure if I write substance use or the insurance will pay? And it's okay. So he didn't know. He said, I'm not. Then he said, okay, I did write. But now he came on Saturday, told me he can't see me now because the insurance has withdrawn. They won't pay. So you see now, already, that's a policy thing. It's like, we will pay if you have an illness, but this illness is dodgy. We don't trust it. We're not even sure it's an illness. You brought it on yourself. We're not going to, so to speak, throw away money on that. So I see that is an area where we need to work on, especially the access. If someone has a problem, how easily are they able to access? If someone went, say, to our national hospitals with a substance use disorder or substance dependence, how will they be received? Will the medical practitioners say, well, we have people here with serious illnesses and you're coming now with your drugging or whatever? So there's a kind of a stigma, a kind of an attitude that's not very healthy. So that's an area that I feel we need to also look at. And lastly, as I end my 2 minutes, it's about prevention. In USIU, we've tried to have a few prevention, all the time we have prevention programs and campaigns. But what sometimes saddens me is that the people for whom we are setting it up don't come. The students who are out there abusing, we don't see them. Again, don't come. So I always ask myself, how can we reach those? How can we reach those who are now down there in the doldrums, drinking, using, and everything? How do we reach them so that we can prevent, we can help them get out of it? And how do we, when we are doing the prevention, how do we even reach these very vulnerable, who sometimes don't even want to come in groups, isolate, tend to be by themselves, and so on. Yeah, thank you. Let me say that for now.
Thank you very much. In response, go where they are, if you do know where they are. And yes. I'll give this opportunity. I'm going to read from Duncan Deritu. It's true the issue of government-run rehabilitation centers is a big hindrance to the treatment of substance use disorders. Again, involving those with lived experience in treatment is a big hindrance. The staffing of many rehabilitation centers is wanting. Boniface Dirangu, you represent, at least from the private sector end, rehabilitation centers. Go ahead, sir.
Thank you very much. And thank you for this forum, ISSUP Kenya, and the people who are leading this. I identify with a lot of the things that have been shared. Thanks, Suzanne. As I represent the Association of Rehab Centers across the country, we have about 135 members, rehabilitation centers. And for a long time, even before the government sought out to start to do this, a lot of people kind of fill up the gaps. When government is slow to get around to do anything, they identify opportunities, they see a need, and they begin to raise the resources and programs around it. So a lot of the rehab centers that I represent started off like that. The majority of them, you will find, are people who had an alcohol drug problem themselves, got help, and thought that maybe they would like to spend a lot of their life or their lifetime in helping others. So those are a few of those. And of course, we have a number of professionals, psychiatrists, doctors who have also come together to start rehabilitation centers. Now, on the topic of today, I see for sure, like in our own experience, first time we got involved in running treatment centers as one of the people who started about 15 years ago. We thought that when we got into rehab, that the only people we wanted to deal with are people who had an alcohol drug problem. At least that's what we thought. Within a very short time, shock on us, because the mental health issues start to show up, and you have to deal with it because it is something you just take to a psychiatrist and they deal with it. Within a short period of time, we have seen that in actual fact, the majority of the clients in most treatment centers, in our rehab centers for sure, between 50, 60, 70% who have a co-occurring mental health issue. So it just takes back to the drawing boards, how closely can we work with psychiatrists? So most rehabs you'll find now have a psychiatric nurse and have somebody or a medical psychologist or work on call with medical person who can help translate some or administer the medication that is required for the mental health issues. In the last research by NACADA, they at least incorporated the mental health component in their research, and they found a serious correlation between depression and alcohol substance use, anxiety and depression with alcohol substance abuse. There's a major correlation between marijuana and mental health issues. Which comes first? Sometimes it is almost impossible to tell. When many people call me, and I have received more than 15,000 phone calls in the last 10 years. Many people call me. There is a substance use of marijuana, and there is always lagging behind a mental health issue. It's almost like follows. That is why they are calling. Before, they didn't call. But you will find that marijuana substance use of marijuana, that my boy is smoking pot, and when you inquire further, you will find that this person has already started hallucinating, that this person has already started behaving in funny ways, and will need to be admitted in a medical psychiatric unit. So far, maybe in introduction, that's what I can say. I think I spent more than 2 minutes, and if you allow me, I can talk about it. Yes, Michael.
I'm sure you can. And what we've done, USIU is working on some prevention and can also see the actual effects within the services offered within the university. You've spoken about some prevention measures that are being taken. And now I quickly shifted to rehabilitation, which is primarily treatment. Boniface, just before I step to the ladies who are waiting, might you be aware of those things that are being done to get you out of business? In terms of prevention, so that we don't get people getting to go to your rehab centers.
Yes.
Yeah.
Actually, our association is addiction prevention, not just addiction.
Yeah.
Addictions, because there are quite a number these days. Even some that are not substance oriented. There's gambling. Yes. There's a lot of addictions essentially.
Correct.
Prevention is it's the way to go. Mike, the magnitude of the problem is such that the only way to go is prevention. That the magnitude of the problem is so huge, we are not even coping up with 5% of the problem. We have calculated, with the current research, we have looked at, even if all our beds were full, we would not be doing 10,000 people. While according to the research, close to 500, 400,000 are in dire street need of rehabilitation. So the problem is so huge that we're not worried about. Most people can't even afford rehabilitation. Yeah, and this problem is huge. So prevention is the way to go. Even us, we would rather invest in prevention. We would rather work with communities, community health promoters, inform, educate, and work to prevent, there will always be close to 8 to 10% of population that will need treatment. But as it is right now, it is not the concern about prevention being like a space where it will prevent people from coming to rehab is still far-fetched, very far-fetched, because of the nature of the problem, the extent of the problem, and the need to invest in prevention.
Thank you, Boniface. So you've made it clear that what we're discussing today is of great and grave importance. I'm going to come back then to Dr. Pamela before I ask for assistance by Albert. But Dr. Pamela, then, you're involved in prevention strategies, and Dr. Gitau has elaborated several of the possible ways in which we can prevent. In your experience over, like this year, what's the success rate? Where do you see an increasing need for the work of prevention? So first, what are you doing, and where do you see the increasing need?
Okay, thank you. Thank you.
And may I encourage members to just write their questions, and you can even say specifically to who. We've seen some. We're hoping to have Honorable Kibagendi show us that he's with us before we actually place the questions. Go ahead, Dr. Pamela.
Okay, thank you so very much for the question. Thank you, our presenters. I want to pick from where Dr. Susan spoke, pointing to the complex issue at hand in this country, looking at the numbers of substances that are being abused, therefore putting many people at risk, and presenting this mental health issue, substance abuse issues as complex brain conditions. So for ISSUP, what we do is to ensure that as many as possible, the responders, the professionals in this space have capacity to respond, because you would rather give proper treatment so that then prevention is possible. Because
what do you mean by capacity to respond?
Okay, capacity to respond in terms of enhancing the skills set of the people in the space of substance use prevention and treatment. Because this disease is so complex. And if we do it the wrong way, then we worsen the situation. And that's why ISSUP is very key in professionalizing this science, training as many people as possible. We have about 1,500 members in the country. Each of them has one training course or another. I presented the various courses that we have. It becomes an entry point for anyone depending on what you are doing. Are you involved in prevention? Then do a prevention course. If it is treatment or even recovery coach, because we realize the community is very, very significant. And the family, as was said by Dr. Susan, as well as Honorable Kibagendi made mention of it, the role of the family. So if we have many people with the capacity, then prevention won't be possible, because we can be able to identify the risk factors and intervene before one develops a substance use disorder. In fact, before initiation of substance use, if we build capacity in schools, build capacity in the communities, build the capacity in the workplaces, then it will be very good for us as ISSUP. So this network of professionals needs to be enhanced, and that's why this awareness is very key for us. So besides also capacity building, we reach out to the communities through our members at their various centers to build capacity of the community, to support the family, to be able to prevent relapse, because relapse is also a very high likeliness. But when we build capacity, then even for the people in treatment, they will be able to prevent relapse to substance use. And that really is very important, and synergy for us is key. That's why we work with APRAC. That's why we work with the schools. That's why we reach out to the universities like the USIU, and also reach out to our professionals wherever they are, because we know the more people get involved, the better it gets for the country, because universal health coverage is key for this country. The danger that we are predisposed to, inability to achieve our goals as a nation, will likely happen because substance use, mental health is a big challenge. So, Michael, ISSUP is trying to raise the bar, to reach out, to build capacity, to synergize, because we know it is important that we do it professionally. We remove the quacks in the space, because if in a rehab, the clients go to the rehab and they are not managed by trained professionals, then it becomes dangerous for them. Diagnosis will not happen the right way, therefore treatment will not be done well.
All right. Thank you, Dr. Kaigura. I'm going to ask Albert, just stop me when you so wish to.
I do want to jump in here, Michael, because there's something that has been brought up, which I'd like us to get to specifics. The people attending this webinar are largely professionals or budding professionals as students. So we're all dealing with these things in one way or another. Dr. Njoroge has raised a practical problem. USIU has prevention strategies and programs, but when the rubber meets the road, they find it difficult to reach the most vulnerable. And those who have studied prevention science know that a lot of it is about assessing and establishing who are the most vulnerable populations and coming up with specific strategies to reach them. So we have prevention experts here. We have Dr. Njoroge, Dr. Getao, Dr. Stella, Boniface, Dr. Pamela. You've all dealt with this. Practically, how do we make our prevention interventions more effective? I open it to the panel as a whole.
Yeah.
Go ahead, Boniface.
Thank you, Albert. I'm very keen on this because I went for some training in Israel where they do this kind of stuff. And one of the interesting things that they did, had Njoroge mentioned, is that the people who are drinking are in the bars. So you have to find a way in which we have programs that are meeting them where they are. So a university such as USIU would have a program where you have people who kind of, in a sober manner, without interfering with people who are drinking outside, present in those places. So they would have patrols, they call them parental patrols, where they don't interfere, but they are there. So if somebody has a problem with they've drunk too much, they're puking, they're helped to get out of there, identified and taken to a safe space, given something to drink and removed. It just reduces the harm, and you start to identify people who have a problem and connect with these people from where they live. So community-based programs that have that kind of patrol, they have to be developed. We have to have interventions that are specific to these populations, these young populations between the ages of 18 and 24. They have to be developed, they have to be nuanced, they have to be where they are, and pick out from there. That's short interventions, not necessarily rehab, intervene, practical. No one will do it. You have to do it. Somebody has to do it. Otherwise, this problem will just be talking. We'll just be talking about it. Yeah, short interventions, brief interventions, even developing hostels that are specific to these populations. One of the hostels can just be set aside a quietus residence, for example, that is specific to this problem. So these students who have been identified, known to use, are using, and you can look at the results. You just need to look at the patterns, all the indicators that show you certain group of students are having a problem, to know that this person needs an intervention, and that it kicks in a housing program. So some of these things, Albert, thank you for narrowing us down to some of the solutions. That's not even now prevention, it's early intervention. Early intervention, if interventions can minimize the development of a serious onset of the problem. I just thought I should mention that.
Thank you for that, Boniface. But yes, Dr. Njoroge.
Thank you. I did bring up this, and I remember Michael said, commenting, go where they are. And you know, I was saying that because it's something I've seen. There's one time I invited Alcoholics Anonymous to come to USIU. And they graciously came. I think 8 guys came. And we went to the auditorium. And nobody turned up. So they just said, okay, let's just have a meeting. They formed and they had their meeting. So anyway, I agree with what Boniface was saying. We need to go to them. And to do that, you need to be very creative. Remember, you're going to guys who are high. They might be belligerent. They could be even, some might tend to be a bit violent or very dismissive. But people need to sit down, brainstorm, think of programs that will attract them and go where they are. But how do you go where they are? Interfering with their activity or whatever they're partaking. So that calls for a lot of creativity and a lot of even concern, so that we are not going to show we are ostracizing them. They are different. We are going to kind of include them, to say, no, you are part of us. We want you to be with us also. And for them to feel that and to be engaged, that we're not judging them, we're just extending this olive branch, say, hey, we have this, in case you want, you come for it. And I'm saying again this because I've seen many times. I talk to parents who tell me, oh, my son, this and that son doesn't want to engage, because as we all know, one of the problems with addiction is denial. One of the people will say, I'm not that bad, I'm not that this, I'm not. So to kind of get in for him to see, yeah, you are actually that bad, without them to do it in a way that they don't feel judged, they don't feel condemned, they still feel accepted, saying, oh, but there's this thing here and there's this thing there. So that's what I meant, that we need to sit down and think of creative ways, even as we mount prevention programs that the most of the university or the community will come to. How do we reach that guy who sleeps in the gutter? Every morning I pass him there in the gutter. Or that student who I see never comes to class, and I know it's because he's drinking. So to say, okay, him we can't prevent, he's already in it, but how do we reach him? In a way that he won't dismiss us, he won't get angry at us, he won't say, get out of my business, this is my business, this is my life, I can do with it what I want. So in a way that will allow them to hear what we are coming to tell them and so on. That's what I was talking, and we need to think really how we can do that. Thank you.
Thank you so much for that, Dr. Njoroge. I'm listening to that and thinking, while going to bars to look for those who are already in the problem, they need help. But I'm thinking, isn't that a bit late? How can we reach them before they end up in that bar? Dr. Susan, you seemed quite animated there.
Yes, I'm here and I'm listening to all of you. Maybe I've been in the field for too long, 25 years. I like the question that Mike had asked. What are you doing as far as prevention is concerned? And I've been doing this for quite some time. Incidentally, I'm in ISSUP, I'm in APRAC. So meaning that I'm in the organizations that are really dealing with the issues of prevention and of treatment at the same time. So if we start from the beginning, is that in prevention, we try to make sure that those who have not started do not start at all. And those that have been introduced to the substances, then they do not progress to SUD. And then those ones who are affected, majority in Kenya are affected, then we need to treat them. So we won't allow them to continue and die. We need to treat them. So at no time will we have a gap. So the trainings where we are using evidence-based, and that is ISSUP is all about evidence-based. So if you call people and you don't have the evidence-based way of dealing with them, the reality is people have always been talking to them. The easiest example I give, by the time a client is coming to me, they have tried everything from threatening them, taking them to jail, taking them to pastors, doing everything they think they know. So if that has not worked, then what is it that I'll bring that will work for them? Is the evidence-based therapist. So continuum of care is whereby we have been talking about aftercare for a long time, but we realize that addiction is progressive. So we also need to have a continuum of care. So when we're doing the prevention with the psychoeducation, at least let it be evidence-based. If you're doing the individualized treatment plans, let an assessment be done, because that condition that is affecting Professor Njoroge there will not, and if you bring in Albert here, even though they could all be having an alcohol problem, everybody is different. So assessments are very important so that you know where are you coming from, what treatment is best for so-and-so and the other person. So individualized treatment plans are very important. The ongoing, I work with people in recovery, and there are things they have taught me I didn't see in any book, I didn't see anywhere. If I'm not having people in recovery who have lived the experiences and they're able to support, where somebody didn't go to rehab but went to AA and they're in recovery, they never went to any rehab. So what is this that people who have lived the experience, what do they know that we don't know? So working with them, the support groups is very, very important. And of course, the relapse prevention techniques. What are they? Which ones are working? Which ones are not working? So it's a continuum of care constantly. At no time are we leaving a gap, because when we leave that gap, then when that somebody slips, and we know right now, addiction in Kenya is an epidemic. We are not putting enough emphasis that this is an epidemic. We are losing people. People are committing suicide. We've not connected this alcohol or substance use with mental health and then suicide. These things are connected. So we need to do serious interventions as early as possible. And I still believe that family should be the first line of prevention as far as substance use and alcohol use are concerned. Thank you.
Thank you for that, Dr. Susan.
Before
yeah. Go ahead, Michael.
Go ahead. I just wanted to, off the what Dr. Susan has just said, how would you advise Dr. Susan, someone who is here, how could I help my children or younger people at home not begin using? Just some practical things that you would say.
Very practical. Don't use yourself.
I hear your Sister Nice, so please go ahead, Sister Nice.
Yes, I'm Sister Nice. I'm saying you don't use yourself. You're the role model. So the children don't do what they are told. They do what they see. So you need to be a very good role model. Communication, so that you're communicating with them from the time they are young and into their teenage and the young adulthood. Keep the communication open. Let them know, what do you expect of them? Don't assume that they know. There's this thing that we have said for the longest time to young people, that the day you'll make your money, get your money, you can drink, I don't care. That's what parents have been saying. So they're not saying don't drink or don't use. Wait until you get your money and then you can use. So the young people I'm working with, I'm currently in my Nyeri office. They come in, they tell you, I was told I can use my money. My pocket money is my money. I was told that when I'll get my money, I can use. So parents are not aware. What are they saying? What should they say? How should they behave? What are they exposing the children to? And culturally, we have normalized alcohol use. So parents have good communication skills, let the children know their boundaries, let them know what they are exposed to. And I bring this very strongly, the use of spirituality. Let them know about God, the way you understand God. These are some of the prevention methods that have worked before, whereby kids are sent. I do what we call toxicology. You're sent by 7 kids who have been caught smoking. And the teacher wants to know, what are they really using? And you find one who is not using. And my question is, why are you not using? And they tell me, you don't know my father. So I expect the father is a harsh guy. Then he says, no, we've talked with my father. I want to be an engineer like him. He told me the day I smoke bangi, I won't achieve anything. So for him, he will stay, watch the others smoking with all the peer pressure and everything. But because of this relationship he has with his father, he makes that decision. I will not use. How many fathers can stand and say, I have talked to my son and I know for sure, whatever situation he will be in, his self-esteem is right. He knows this is how I want things. He knows I'm here to support him. How many fathers can stand up and say that? So the family can make a big difference as far as substance use and alcohol use is concerned.
If I might chime in there a little bit, to just add on to what Daktari has said, I think even the involvement, being involved with kids from the very young age, so that you bond with them and get involved with them in their lives, in everything they do, so that as they grow, they feel they're all right as human beings. There is nothing, they feel that there is no, if I might say, angst or some kind of thing they feel they missed out on. So that way they grow up feeling complete and so on, and chances of abusing substances are less. So in a way, you can say that family needs to be a family that is functional, it's functioning. And one of the ways, what Daktari was saying, and that being very involved in the life of the children. Thank you.
If I may add, just chip in with what Daktari and Njoroge are saying. A major part of how we ensure that our kids is engaged in the positive engagement and positive psychology during certain age group between the age of 9 to 18, when they start to experiment. It's so critical, ensuring that they have a fun life, that they can actually have fun, a lot of fun without using. Ensuring their life is engaging, ensuring that they feel that there's somebody who really cares about them. Now, that is the first lot of positives. A long time ago, before almost all the spaces was stolen in Nairobi, we used to have social halls, used to have dancing, utamaduni, and utamaduni day like today, there would have been traditional dances. People were engaged positively. And that's why when Dr. Sudan says spirituality, there is something there that shows that people are able to avoid using. It's also the engagement with church. The Sunday after church, there's activities that the church organizes for this young lot of people. So ensuring that our kids are positively engaged from very early on. Now, of course, there will be a few who will have to experiment. And that is not, it's just it is just, it will happen. It will happen. Some of them will have to experiment. Some of them will have to even start making it a habit. We must also differentiate between that experimentation, that habituation that is beginning to form, and addiction. So how do we develop interventions that reduce the harm when they are experimenting? It is very sad that most universities and management have allowed their neighborhoods or neighbor areas almost like a freelance, free-for-all community with no intervention, no supervision, no. For young adults, they are very young, and there are so many living around campuses, unsupervised at all. That is the breeding ground for most. In fact, if you want to set up a rehab, a proper rehab that will never miss clients, just set it up near any of the universities. You will get clients. You will always have clients. Just near university, there's a stream of people who have a problem growing up between the ages of 18 to 24. So we need universities and parents and communities like community health workers, the ones that have just come up now called community health promoters, because they will be running about 100 homes, a program that intervenes for this population, for this young population. And it doesn't mean rehab. It only means supervision, interventions, and referrals when necessary, and harm reduction. Because the harm that happens when these young people start to experiment, that's why you get a lot of them, break their virginity, and they sometimes through rape. People experiment drugs they don't know about the first time. They don't even have an alcohol drug problem. And those drugs give them such traumatic experiences that they start to use again, just to forget what happened during the first time use. So we need to save up our communities, ensure that there are some people watching, there are some people intervening, and these people are trained. It's a training. It's not just anyone decides they're going to be a kanjo of sorts. No, it's a training, a proper training, how to intervene, where to intervene, when to intervene, who to use. So those are the people I think I would be suggesting that people, the community health workers, community health promoters, with the Parents Association, and trained addiction professionals like Dr. Susan Gitao to supervise. We will start to have interventions that reduce the harm among those that are beginning to start to use. Our Honorable Kibageti can help us with that to ensure that almost all these community health promoters are trained on the mental health issues and trained on addiction issues, just to be conversant with that. That is, and especially if we target the areas that the universities are, or high schools that are, or TVETs, those are places of high likelihood to have substance use problems beginning to seep in. That's how prevention will start to work, will reduce the number of people who are beginning to develop a problem. Thank you.
Thank you for that, Boniface. I saw Dr. Pam with your hand up, but let me go to Dr. Stella first, who has also got her hand up.
Thank you. I just wanted to add that parents should put more emphasis on what children should do to deal with stress much more than what they should not do. I remember when I was in campus, my late mother took me for a sauna and a massage at Silver Springs Hotel, the 90s. And I go up to now, and it is an excellent coping mechanism for me. And so parents need to, knowing their children, give them appropriate coping techniques, coping skills for them to deal with stress, because stress will come whether they like it or not, at one time in the future or not. And then families also need to learn to intervene when traumatic events happen in the homes. There is a death, there is divorce. Parents need to know that the children are affected whether they show it or not, because those are the things that push the children to using substances as a coping mechanism. And at university level, as my colleague Njoroge was saying, maybe we need to start a support group for students who don't take substances, because peer pressure is real. I know at my age, when I go out with my friends and they want to take, I have a genetic predisposition to alcoholism, and because of that, I don't take. But the pressure is so much. Maybe we need to start glamorizing not taking. We need to offer support to students who don't take, so that they learn better assertiveness skills, so that they know that you can still be cool even without taking substances. Maybe we should organize a march for people who don't take substances so that they can know that it's actually okay not to take.
Michael, thank you, Dr. Stella. Dr. Pamela, before we go to Michael, you had your hand up as well, please.
Really, I just wanted to emphasize the bit of the family. Family is the basic unit of the society. Before the children find their way to church or mosque, they have come from a family. So if the family is able to be a good environment so that the stresses of life, the child is not feeling neglected, the environment at the family level is not a risky environment, that could be a very good beginning, so that by the time we are sending these children to the church, to the school, they are stable in a way that they can even be able to communicate to us and even pass the right information to the others. But of course, we are looking at also another factor. The poverty levels is a big challenge because it is leading to a lot of anxieties that are being medicated by substance use. I think the legal frameworks need to be enhanced. People need to be empowered economically so that then they are not they are not resorting to substance use or sales of substances as the only business that is doing well now. Where I live, the number of bars and outlets of substance use are more than the supermarkets. So the availability of these substances is a big challenge. I think the legal system needs to be strengthened, the frameworks need to be strengthened, and also the laws observed so that we can have safe spaces for our people. Thank you.
Thank you, Dr. Pamela. Michael?
Thank you very much, Albert. As we tie up and wind down the conversation, which I think could have gone on for a while yet, may I ask a very brief question for a very brief and concise response, maybe even point form? What research, now that we have academia in the house, would be helpful to increase capacity to prevent substance use? And if you can just point out very quickly as our panelists, what is that? And those who are in attendance, you can put it in the chat and we can communicate, and USIU can have this information. So, Dr. Susan, what are 2 or 3 areas you think? Research this, this, and this. We can't hear you yet. Yes, go ahead.
Adolescents.
What about adolescents?
They're the most affected and influenced into substance use. So we need to do research. What can we do for them so that they don't go that way?
All right, thank you.
Trauma has really caused most people to go into substance use. And a very special group, women. We're having women who have serious alcohol and substance use, but because of our culture and why we hide them. So we don't have a lot of research. Even most of rehabs in Kenya are more on male and how male treatment should be done. So we don't have evidence. This is the time it's coming up about how to treat women who have alcohol substance use.
Thank you. Thank you, Dr. Gitao. Dr. Pamela Kaithuru.
If we can be able to map out who is skilled enough so that at the community level, we know where can people get help, who is available to create awareness, where are the resources that people can resort to, so that in a family, if I realize something, is there a health facility that I can go to that as a professional who can be able to support? So we need to map out the resource persons and the resources for this response.
Thank you. Thank you. I was going to ask Boniface to contribute. I'm not going to ask Mr. Njoroge and Dr. Nyagwenche because they're in academia and they already have ideas of their own. So let me quickly go and see, some shops, says Daniel, are drug dens, like the one selling movie snacks, sweets. I'm told there's biscuits and cakes mixed up with drugs, so our children, innocent consumers, and they start getting used to it, even without knowing. Thank you for that. Asha says, well said, substance use is a symptom. Let us address the issues at the root. We need to teach people how to cope with stress changes. I've got a few more comments, if you'd allow me to track them and share them. Some of the sports facilities, says Anreed Kamunde, are drug dens. Prevention is better than cure. Teach life skills in primary schools. And I think that's what we've spoken about, starting from home and going out into schools. Psychoeducation is key. Media, says Edwin, is an instrumental tool in this campaign. Cross-pollination of information through social media. So ISSUP, jump into social media if you're not already there. And finally, role modeling from parents, as has been emphasized and re-emphasized. Damaris says family should be the first entry point. I just wonder what happens to families where most members, especially the family heads, are addicts. So what do you do? And that's also something interesting to probably research. What are you doing about the mass supply of these substances is concerned as part of prevention, says Samson Kaume. Yes, unfortunately, the honorable member dropped off, but it would have been good questions to put through to him. More facilities all over should be all over. Public facilities, I think, is what Bernard was referring to for rehabilitation. And I'm going to stop there and quickly check questions that might have. Catherine, thank you for your input with regard to the work that you're doing. And Edwin, you asked questions that were targeted to the honorable member, so we couldn't quite get him to answer that. And the question regarding how one can register for ISSUP, we're going to inbox you just now, but there is an email that you can use. And finally, Albert, I think now, can I give 30 seconds for final comments from each panelist who is still here? Oh, Boniface is back, great. Each panelist who is here, 30 seconds, and then we'll hand over to Dr. Nyakwencha to hopefully summarize an hour and 50 minutes of discussion in 5 minutes. So we begin again with, all right, Dr. Susan, go ahead, you begin.
Decriminalize substance abuse. Decriminalize substance abuse. That's my end.
Thank you. Decriminalize substance abuse. Thank you, Dr. Gitao. Now that the ladies have started, Dr. Kaiduru.
Seek professional support. Let us get to know who is supporting you. Are they trained? Because if then they are not trained, they could make the case worse for our people. Professional support.
For both prevention and treatment is what I guess you're mentioning, yeah?
Sure.
Thank you. Thank you. Who is younger between Boniface and Joseph? Anyway, let's go with Joseph first, please. Joseph Jorge.
Yes. First of all, is the availability. Whatever happened to that, was it the Motudo rule or something about removing vendors or bars from near institutions, so that to make it very difficult for students to access? That's one. And then anomie in society, to address that. For like now, people talk about there's a lot of stress, this and that and the other, and people will tend to use. So to see how that can be addressed, because there could be a correlation between that and the increase in substance use.
Thank you. Thank you very much, Mr. Njoroge. And finally, Mr. Jirangu.
Thank you very much. I think one, I would really propagate for positive psychology and positive engagement of that young population as early as possible. So a very active focus on how to engage them positively through music, art, sports, generally positive engagement activities. And maybe I would add a targeted harm reduction approach to early first-time users and early spaces of using. So finding interventions for spaces where people start to use and developing targeted interventions for this population would minimize the development of the problem and reduce the harm to that population.
Thank you very much, Boniface. And as I hand now for the wind up by Dr. Stella Nyagwencha, ISSUP is where you want to join as a professional in the field to help with both the prevention and treatment. And USIU is the place you want to join to increase your capacity and capability, specifically the PsyD program, a doctoral program, which is a practitioner model developed to meet the challenges of the society over and beyond the developed PhDs that are developed for academia. So with that, Albert, can I say thank you on your behalf and then hand over to Dr. Nyagwencha to give us the summary.
Thank you very much, Mr. Oyer. What has come out very clearly in this webinar for me is that I know we all take away different things, but for me, this is what has come out very clearly. Mental health is a basic human right for all people, and everyone, whoever and wherever they are, has a deserving and inherent right to the highest attainable standard of mental health, as mental illness is not self-inflicted, it is an illness, as we have heard today. And that includes that everyone has a right to available, accessible, acceptable, and good quality care. Having a mental health condition should never be a reason to deprive a person of their human rights or to exclude them from decisions about their own health. Now, having had the grim scenario about statistics on mental health and substance use disorder, it's not hard to understand why preventing mental disorders and promoting mental health is of immense interest to psychologists, researchers, policymakers, and you and I at a personal level. The sad reality is that there could never be a sufficient number of counselors and clinicians trained to provide all the needed mental health services for the populations. Albert in 1959 in America said that mathematically it is impossible to train enough mental health professionals to provide services to everyone who needed it, just like there would never be enough chairs in a game of musical chairs. And so to reduce the burden of mental disorders, it's essential that greater attention be given to prevention and promotion of good mental health at the level of policy formulation, legislation, decision-making, resource allocation, and the overall healthcare system. The question that I want to leave with you as I come to the end, or as we come to the end of this webinar is, what can you do at an individual level to promote mental health? What can you do in your organization and the community at large to prevent people from developing mental disorders? It's very easy for us to blame the government, management, members of parliament, and whoever you so wish. But the question remains, what is your role in enhancing good mental health? I'm proud to be part of the USIU-Africa community, where we are committed to excellence as we train competent mental health professionals in the various programs that we offer. As you're aware, we have a BA in psychology, MA counseling psychology, MA clinical psychology, MA marriage and family therapy, and Doctor of Clinical Psychology, as you have heard. We strive to improve human rights by preparing psychologists who will provide good quality mental health services. And so if you're looking for a place to be, as Oyer said, USIU is the place. As I conclude, please note that we are one, as we say at USIU. That means if one of us hurts, we all hurt. If one of us has a mental illness, including substance use disorder, we are all affected in one way or the other. Let us then care for our own mental health, even as we strive to improve the mental health of our brothers, our neighbors, and the community at large. I was asked to also give a vote of thanks, and so I'd like to take this opportunity. I just want to begin by thanking God for making this possible, and even just for bringing us together. I met ISSUP when they came to USIU for a stakeholders meeting, and I'm glad that we have been able to develop a relationship. I know our meeting was not by accident, and so I thank God for that. I'd like to thank Honorable Anthony Kibagendia. I know he has stepped or dropped out, Chairman, Parliamentary Caucus Against Drug and Substance Use, for giving the keynote presentation and finding time to be here. I would also like to thank in absentia, I'm not so sure that he's still in, USIU-Africa Deputy Vice Chancellor, Transformative Teaching, Learning and Research, Prof. Amos Njuguna, for finding time to be here despite his busy schedule. A special thank you to Dr. Susan Gitau, as well as the other panelists, Mr. Joseph Njoroge, Mr. Boniface Ndirangu, Dr. Pamela Kaithuru from ISSUP. Thank you very much for your input. A special thank you to the moderators, Mr. Michael Oyer from USIU-Africa, and Mr. Albert Muraya from ISSUP. Thank you very much for the good moderation that you have done. I want to thank all the participants who found time to be here. Today is a public holiday and Kenyans are busy. Thank you for being here or spending 2 hours with us. Please feel appreciated. I also want to appreciate ISSUP for agreeing to partner with the Department of Psychology at USIU-Africa. We look forward to working with you more in future to make a difference in the field of mental health. And so in case I have left you out and I should have appreciated you, I've seen many colleagues, many students, people from different countries. I've seen Rwanda, I have seen Qatar. Thank you very much for coming. Please feel appreciated. Thank you. And back to the moderators.
Thank you so much, Dr. Stella, for those wonderful closing remarks. To our panelists, Dr. Susan Gitau, Dr. Joseph Njoroge, Mr. Boniface Ndirangu, Dr. Pamela Kaithuru, our president at ISSUP, Honorable Kibagendi, and Professor Njuguna. We thank you all for your engagement, and look out for more of these webinars from ISSUP and as well as from USIU. So with that, we thank you and bid you good night. Happy Huduma Day.
Bye, and happy Huduma Day to you too.